So actually, the Venturi principle is mainly for the types of Sanders or Manujet ventilators. Jet ventilators only employ the or use the Venturi principle to enhance the tidal volume or delivered gases to the patient. Whereas the high frequency jet ventilators, they make at the rate of 150 to even 400 to 600 breaths per minute. The frequency can be set up to 400 or 600 breaths per minute depending upon the situation. There it is not the Venturi principle which delivers the gases. It is by the oscillations which go rotating the gases into the air passage without the need for any diaphragmatic or other ventilatory muscles to act. So it is the bulk movement, as you said. The four principles are pendulum, the dispersion, the bulk movement, and the cardiogenic movement. These are the four methods by which the gases are propelled into the respiratory passages and to reach up to the alveolar level. So that is the principle under which they are working, and the high pressure jet is broken down by the solenoid valves are interrupted to reduce the volumes to deliver the tidal volume that is required. That is what is happening inside the machine. A high pressure gas source is interrupted by either an electrical or a solenoid or another gas to break the force or volume that is coming out into smaller volumes which are delivered into the patient. So I'll just show a small presentation on that. Most of the points what she has mentioned very nicely will be there in that.
So duration of surgery under jet ventilation and carbon dioxide elimination, sir. I think she didn't mention that, sir.
Yeah, they have to time it. It is tracheal reconstructions and bronchial reconstructions are mainly done with this sort of procedures because you don't want a tube there. So this is useful in that sort of cases also. And as you mentioned, you have to have an ABG line to measure the carbon dioxide level rather than depend on the EtCO2 for these cases. So you can maintain the anesthesia with the TIVA for these cases and then deliver the jet ventilation. And depending upon the EtCO2, PaCO2 value, you can decide the duration of surgery and indicate to the surgeon how long you can proceed and complete the surgery within the available time. So the question is principles of jet ventilation, types, indication, advantages, disadvantages, and complications. This question has been asked in the theory examination 2 or 3 times repeatedly. So jet streams originating from high pressure source are cut by pneumatic or electronic operated interruption devices. This generates a tidal volume that is supplemented by entrainment of gases also. So expiration is dependent on passive lung chest wall recoil. So it is only the inspiratory force that is required because the chest wall recoil will take care of the expiration. And pendulum describes the movement of gas between lung units with different time concept. Is one property that is required. And convective streaming or Taylor dispersion is another result of asymmetrical velocity profile of the inspired gas that moves through the bronchial tree. And cardiogenic mixing by the beating heart enhances gas exchange through agitation of surrounding lung tissue and molecular diffusion. Bulk flow may contribute partially to gas exchange as the leading edge of the gas front may actually reach a number of proximal alveoli. So the principles are actually these four: pendulum, convective streaming, cardiogenic mixing, and bulk flow. And the resultant is the entrapment or Venturi effect. Now types are high or low frequency. So low frequency is usually applied with a hand triggered device such as Sanders injector or Manujet. and its application is limited to short investigative procedures such as laryngoscopy or bronchoscopy, like foreign body removal or examination and anesthesia or a biopsy or small removal of vocal cord polyp. All these procedures, which are not very time consuming, can be easily done through this. And it is also useful in can't intubate, can't ventilate scenario, where you through a carotid cannula, you can give low frequency jet ventilation. Whereas high frequency requires equipment and familiarity, and commercial ventilators which deliver heated humidified jets at 1 to 10 Hertz, and continuous flow is chopped into square wave pressure by high frequency flow interrupter, which is usually an electrical solenoid valve or can be fluidic or rotating cylinder valve. So this is the mechanism by which the uh, high frequency ventilation is created. So the factors which judge the or which can be adjusted are driving pressure, frequency, inspiration time, and composition of jet gas. So what are the indications for jet ventilation? As you rightly said, can be classified into emergency, where it can be a life-saving measure in especially low frequency jet ventilation in a can't intubate, can't ventilate scenario. Whereas in elective, you can use it as preemptive for placing a transtracheal jet cannula during laryngoscopy or vocal cord surgery. And in ENT procedures, diagnostic laryngoscopy, you can use it, or for where you want immobility of vocal cords for any vocal cord microlaryngeal surgeries, this can be used. And the jet ventilation catheters are constructed in such a way that they are non-flammable fluoroplastic material. So you can use them with laser without fear of airway fire. And in thoracic surgery, it creates again the advantage is it causes a motionless field. So in tracheo or bronchial reconstruction or in one lung ventilation during surgery, and in major bronchopleural fistula or tracheobronchial disruptions. These are the indications in thoracic surgery where it can be used. And in radiology, you can use it for radiofrequency ablation of liver tumor or left atrial myxoma ablation, or you can use it in extracorporeal shockwave lithotripsy also, where you don't want the diaphragmatic excursions which will alter the position of the urinary calculus. And critical care, you can use it for lung protective ventilation strategies with low tidal volumes, and you can have reduced pressure swing during ventilatory cycle. The advantages and disadvantages depends on the placement where you deliver the frequency ventilation. One is supraglottic, transtracheal or subglottic, and supraglottic and transtracheal are tubeless. Subglottic, minimal airway increase where you have to pass a catheter to be in the field. And complications, barotrauma, gas trapping, which can impair cardiac output, especially right ventricular and systolic volume will be affected. And if there is a existing right ventricular problem like in pulmonary hypertension or tricuspid diseases, then you will have acute right ventricular failure on the table. So weak RV fails to cope with this increased afterload, and there may be complete loss of cardiac output. And exposure to dry gas, some of them have humidifications nowadays, but the earlier ones were not having humidification. So because of that, you can cause necrotizing tracheobronchitis, atelectasis, loss of ciliated epithelium, mucosal inflammation, excessive mucus and airway plugging. All these things can happen. Hypercapnia is the most important disadvantage with this particular thing. So CO2 elimination is dependent on the frequency and tidal volume raised to the second power of the jet ventilation. So tidal volume is modulated by changing the driving pressure. Most effective way to increase CO2 elimination is to increase the driving pressure without increasing the frequency. Because normal ventilation, we try to hyperventilate. We increase the respiratory rate always to eliminate the CO2. Whereas in jet ventilation, you have to increase the driving pressure and not the frequency. Because that increases in frequency will have less time for CO2 elimination, and so more accumulation of CO2 will happen. Now coming to the complications, of course again whatever has been mentioned is given in this tabular form so that you can easily remember. Barotrauma, the form of pneumothorax, pneumopericardium, pneumomediastinum, subcutaneous emphysema, hypotension and right ventricular failure, all because of high pressure. Because of dry gas, mucosal trauma, tracheal necrosis and atelectasis. And sometimes impaired ventilation will lead to hypoxia, hypercapnia, and airway soiling and debris infiltrations. So this is just a rough method of remembering whatever points that have been beautifully described by Dr. Shruti. So again, congratulations and for the good nice presentation, Dr. Shruti.
Thank you.